So ECMO is extracorporeal membrane oxygenation. So here what happens is that the blood is taken out from the body through a vein, and then it comes back through the either a vein or a artery. There is a pump which is there outside the body which tries to propel the blood after it is drained from the vein, and then through the oxygenator the CO2 is removed and and oxygen is added, and then the blood is pushed back into either a vein or a artery. So when we talk about the VV ECMO, it is the first V stands for the drainage cannula, which is, and the second is through the when it's returned through a vein. So it can be a femorojugular configuration. So it is a VV ECMO, and when it is returned via artery, whether it's a femoral artery, usually it's a femoral artery, so it's a VA ECMO. So these are the two types, VA and VV ECMO. VV ECMO is usually for the respiratory failure only, whereas VA ECMO is due to severe cardiac failure with or without respiratory failure. So cardiac failure, VA is for artery, if you can remember. If it is only a respiratory failure, it's a VV ECMO. So now we want to discuss the extracorporeal CO2 removal. So when we compare the ECCO2R with the full ECMO, you can see the blood flow component. So blood flow is just between 200 to 1 liter or 200 to 500 ml per minute, whereas in full ECMO the blood flow is the complete cardiac output around 2 to 5 liters per minute. So depending on the patient, we try to mimic the full cardiac output or at least 70-80% of the cardiac output in the full ECMO. Whereas when we try to remove only the carbon dioxide from the blood, it is around 200 to 500 ml per minute only. The idea is to remove 40 to 50% of carbon dioxide. But remember, when you try to remove only the carbon dioxide, it won't treat any hypoxemia. So especially in patients who are hypercapnic, we can use a extracorporeal CO2 removal technique. Just to again emphasize the differences, so since we need a larger cannula in ECMO for a higher blood flow, whereas in CO2 removal we need a very decreased blood flow, we can use a double human dialysis cath. So we have also used CRRT machines with pediatric oxygenator to remove the carbon dioxide. So as I told you, we need very less flows between 300 to 1 liter per minute. We need a medium sized oxygenator. There is hardly any blood oxygenation, whereas in the ECMO, it is a full blood oxygenation and full blood decarboxylation, and we need a very high flow to the tune of around 3 to 5 liters per minute. Why do we need extracorporeal CO2 removal? Because patients having hypercapnia, that is higher CO2, it has got its own side effect. There is increased cerebral blood flow, in hypercapnic acidosis, decreased myocardial contractility, and in patients of severe ARDS, we have found that there is acute cor pulmonale in around 20 to 30% of patients. And this increased CO2 has also been associated with poor outcomes in patients with ARDS as a risk factor for mortality. So this again is a study which tells you that severe hypercapnia is one of the risk factors for mortality in patients of moderate to severe ARDS. So what is the physiological basis of CO2 removal? So when you compare the oxygen transport to the CO2 transport, CO2 transport in the blood consists mainly of bicarbonate to the tune of 70 to 75% of the CO2 that is there in the body is being transported as bicarbonate, which is then converted into CO2 and water by carbonic anhydrase, and less than 5% is bound to the hemoglobin. Remember, CO2 diffuses much more rapidly than oxygen. It is almost 20 times more diffusible than oxygen across a gas exchange membrane when the concentration gradient is there. That is why blood decarboxylation is a very efficient and non-limited process compared with oxygenation. And since it is very diffusible, we can remove the carbon dioxide with a very low blood flow as compared to oxygen. Blood flow to the tune of 300 to 1 liters per minute can lead to effective blood decarboxylation. So just to tell you again, the oxygenation requires a blood flow which is very high, and CO2 removal requires a very lower blood flow. When we talk about lower blood flow, we require smaller diameter cannula for lower blood flow. On the top, you can see the circuit. The blue blood is coming out of the patient, which is the venous cannula. Then there is a blood pump. Next to the blood pump is the oxygenator, and then the filtration is there. And if you require a CRT machine, and then it goes back to the patient. This again tells you, if you can see on the x-axis is the extracorporeal blood flow. The blue one is the CO2 graph. So if you see the CO2 graph, if you have a blood flow around about say 0.5 liters per minute, you effectively remove around 50% of oxygen that is there, 50% of carbon dioxide that is there in the blood. But when you want to oxygenate such a patient, you will require up to 3 liters of blood flow to give some bit of oxygen. So that is why it shows that CO2 removal is a much more efficient process because CO2 is much more diffusible. So the efficiency of extracorporeal decarboxylation depends mainly on the four factors. First is the membrane surface area. So larger is the membrane surface area, higher is the removal of CO2. When the inlet PCO2 is higher, when the inlet PCO2 is higher, when the inlet PCO2 is higher, that means that the CO2 concentration gradient is higher. More and more CO2 will be washed out. Then we talk about sweep gas flow. So sweep gas flow is one of the major factors which tells you about efficiency of CO2 removal. Higher the sweep gas flow, higher the CO2 that is removed. Higher the blood flow, higher the CO2 removal is there. But sweep gas flow is the most important thing amongst all these four. When we talk about indications of CO2 removal, so there are two, three things which you can think about. A patient coming to you with exacerbation of COPD or a status asthmaticus. These are the patients when CO2 is very high, and these are the patients who are pH is going down because of hypercapnic acidosis. So you want to try and remove carbon dioxide in these patients. So in this also there are two subset of patients. So when a patient of COPD comes to you with hypercapnic acidosis, the first response is non-invasive ventilation. So when these patients do not respond to non-invasive ventilation, we can think about having an extracorporeal CO2 removal in these patients. The idea is to try to prevent intubation and its related complications. Second is there is a patient who has of COPD exacerbation is already intubated, is on mechanical ventilation. So when this patient on mechanical ventilation, you try to wean him off. You cannot wean him off because the CO2 is high. These are again a subset of patients when extracorporeal CO2 removal has been tried. So you try to remove the carbon dioxide in these patients, and this can actually ease the weaning process. So this is one subset when there is hypercapnic acidosis leading because of acute exacerbation of COPD or status asthmaticus. When you talk about the second subset, so when we talk about ARDS patient management, the whole idea is giving the lung rest. So we give tidal volume of less than 6 ml per kg and plateau pressure of less than 25. So that is what we aim for. But there is a subset of patients who are having severe ARDS in which ultra low tidal volume ventilation is there. So we do allow the CO2 levels to go high, which is called permissive hypercapnia, provided the pH does not drop to below 7.1 or 7.2. So when we allow permissive hypercapnia, especially in patients with ultra low protective ventilation, that is less than 4 ml per kg, there is hypercapnic acidosis. So this is another subset of patients in which moderate to severe ARDS, you allow the CO2 to rise higher. You have to remove the carbon dioxide through extracorporeal CO2 removal. The third subset of patients where it is found useful is patients whose lung has fibrosed and are awaiting a lung transplant. So as a bridge to lung transplant, these are the patients you do not want to intubate such patient. You can put them on extracorporeal CO2 removal just to maintain the CO2 levels in a reasonable limit and to titrate the pH of these patients. So if you see to the right, all the three indications are mentioned. Acute hypercapnic respiratory failure or COPD, again prevention of intubation, that is the risk of NIV failure, or rapid extubation after NIV failure when the patient is intubated. Then a patient, if you can see the CT scan of the lung, there is acute hypoxemic respiratory failure. You try to give ultra low protective ventilation to decrease the ventilator induced lung injury. So these are the subset of patients in which you want to control the hypercapnia induced by ultra low protective ventilation. You try to remove the carbon dioxide in these patients. Then as a bridge to lung transplant. This is ARDS patients. Conventional ventilation tells you that you do a low lung protective ventilation with a P plateau of less than 30 and a tidal volume of less than 6 ml per kg. But especially in severe ARDS, if you can go to a lower tidal volume, it is better. But the risk is hypercapnia. So for hypercapnia, you have a device which is extracorporeal CO2 removal. So then there are few studies which are try to do this so that the hypercapnia side effects like pulmonary artery pressure increase or IV dilatation isn't there. So they try to do in 2 or 3 studies like extra vent. They tried with 3 ml per kg combined with the extracorporeal CO2 removal versus conventional lung ventilation. But what they found was that although so in this they use arteriovenous extracorporeal CO2 removal. When you talk about arteriovenous, that means blood is taken out through a artery, the first alphabet, and goes back to the vein. So the body's own cardiac output or blood pressure is being used as a pump. You just need an oxygenator or a filter. So blood is taken out through artery. You do not need a pump. You have an oxygenator, and the blood goes back to the vein. So usually the femoral artery and femoral vein is being used in these patients. So they tried this in patients of when they use ultra lung protective ventilation with very low tidal volume to less than to 3 to 4 ml per kg. So in the subgroup of PF ratio of less than 150, they realized that they could be weaned slightly faster, but there was no mortality benefit. So they also tried in a what we call a supernova trial. This is a strategy again of ultra low lung protective ventilation in new onset moderate to severe ARDS. They realized that CO2 extracorporeal CO2 removal is a feasible alternative when you have patients with low protective ventilation, and we could have a tidal volume of around 4 ml per kg, limit the plateau pressure to less than 25 centimeters of water, and they suggested that a randomized control trial to be done. Then this rest randomized control trial was being done in 2021. It was published in JAMA. So they concluded that amongst patients with acute hypoxemic respiratory failure, the use of extracorporeal carbon dioxide removal to facilitate lower tidal volume ventilation was feasible, but it did not reduce 90-day mortality. So no mortality benefit was found with extracorporeal CO2 removal, although physiologically it has been proven that it can be used. Then it was different devices were there. If you can see the device column, different devices were there and different subset of patients of COPD and asthma in which the patients had hypercapnia respiratory failure which were done, but no mortality benefit was found. This was the most recent one. This was published in American Journal of Respiratory and Critical Care Medicine. This is a 2024 trial. So in patients with acute exacerbation of COPD, they realized that when they compared extracorporeal CO2 removal with a standard of care to either avoid intubation or to facilitate extubation. In both of the cases, they found that they could not improve the ventilator free days in both of them. And they found that attributable risk associated with bleeding complications during the initiation of ECOR need to be balanced with the benefits of ECOR. So, even in this subset of patients in which who has only hypercapnia due to status asthmaticus or COPD, they could not find any mortality benefit. Although they thought that the study may be underpowered to detect the differences. And there were several trends in the data that are encouraging and hypothesis generating for future studies involving extracorporeal CO2 removal. Again, in asthma, they tried to study this, but there were few machines in which they studied. They actually used very high flows to the tune of 3.2 liters per minute, which was related to VV ECMO. These kind of flows are we used in VV ECMO. So they realized that the beneficial effect of veno-venous ECMO was definitely proven. But when we talk about only CO2 removal, the actual benefits are yet to be proven. So again, I was just telling you, first is to avoid intubation in patients who are having NIV. So you have a subset of patients who are elderly, who do not want to be intubated. You realize that if you intubate them after failure of NIV, you might land up in a tracheostomy. So we can actually try awake extracorporeal CO2 removal in these subset of patients till the time the exacerbating factor is being treated like infection. Then there is a subset of patients who are already intubated. You try to wean them off. You realize that the CO2 is being increased when you try to decrease the ventilatory support. In these subset of patients, again, you can use extracorporeal CO2 removal so that these patients can be easily or better weaned off from the ventilator. Now, I was talking about lung transplant. So, lung transplant is being increasing day by day. So, respiratory failure during bridging to lung transplant can necessitate intubation mechanical ventilation. And when you intubate such patients, it leads to higher significant mortality. So idea is to keep the patients awake, allow them to breathe spontaneously, and you give them extracorporeal to CO2 removal, especially in patients with terminal fibrosis who suffer from predominant hypercapnia. Extracorporeal CO2 removal has been successfully used for patients as a bridge to lung transplant. These are the criteria to initiate in patients of ARDS and COPD especially. So idea is when you talk about ARDS patient, when you have a patient you use ultra lung protective ventilation, these patients increase the CO2 to higher than 80 and the pH drops to below 7.2, you can think about using extracorporeal CO2 removal. In COPD patients, when you realize that the patients are having respiratory failure, hypercapnic ones, and even NIV support is not being able to decrease the CO2 levels, you start with extracorporeal CO2 removal. Again, in patients with COPD patients who are unable to wean after one or two attempts and the patients may land into severe bronchospasm or remain hypercapnic, you can use them. So especially in COPD patients, they have found that who are already intubated, you can decrease the amount of minute ventilation you need to give these patients, and that simultaneously you realize that the auto PEEP is also decreased and these patients are hemodynamically better and weaned off in a much easier way. So when we talk about techniques, so realize that the blood is outside the body. The blood needs some bit of pump or some bit of pressure gradient to move. So when we talk about arteriovenous extracorporeal CO2 removal, as you can see in the B picture, you just have an artificial lung connected to a sweep gas flow, and the body is the blood is drained from femoral artery. The body's own blood pressure is the gradient. It goes to the artificial lung and it goes back to the femoral vein on the other side usually. So this is a arteriovenous extracorporeal CO2 removal. When we talk about venovenous extracorporeal CO2 removal, the blood is taken through a vein. Since there is no pressure, you need a pump here to generate the pressure. Then it goes to the oxygenator or the CO2 removal device and it then goes back to the patient's body. So when we talk about the artificial membrane or the artificial lung, this is connected to the sweep gas flow, which is in extracorporeal CO2 removal, you use a sweep gas of around 8 to 10 liters per minute. And then when the CO2 decreases, you can titrate the sweep gas to a very low level. So arteriovenous CO2 removal, there is a pumpless device. The mean arterial pressure is of at least 70 units of mercury. It is a low resistance circuit and the patient's cardiac index should be at least 3 liters per minute per meter square, so that the blood actually is, you don't require a pump and the blood flow is enough. When you talk about venovenous, I will told you the blood is coming from the vein, then there is a pump, then an artificial lung and goes back to the another vein or the same vein. Various devices and various surface areas with different flow rates are being given. There are some bits in which you can actually use the same device for a CO2 removal and a ECMO as well, like cardio help. When we talk about CRRT, which is a continuous renal replacement therapy, and ECOR, it is usually connected in circuit. So you can see the blood is coming from the patient, going to the blood pump, then the CRRT filter, which can have a pre-dilution as well as a post-dilution replacement fluid, and then the extracorporeal CO2 removal device. So this is the order of ECOR and CRRT setup, which is connected in series. Although it is thought that with lower blood flow and smaller cannulas, the complications rate are lower, but it is not actually so. The bleeding is one of the most higher complications because the less blood flow you have to maintain anticoagulation and you have to measure the ACT and the APTT like you do in ECMO patients. The lesser dimension of the cannulas definitely decrease the chances of bleeding, but you have to maintain the anticoagulation. And both excessive anticoagulation and mechanical shear stress on coagulation proteins significantly increase the risk of bleeding. We are trying to use regional citrate anticoagulation in these patients so that the bleeding complications are lesser, like used in CRRT nowadays. So when we talk about future, what can be there is research with the ultra low lung protective ventilation in severe ARDS. So as there is no mortality benefit, but when we talk about physiology, it is actually feasible to decrease the tidal volume to much further. How much decrease of tidal volume should be there so that we decrease the biotrauma and the willing is yet to be studied. Then a subset of patients who you do not want to intubate in acute respiratory COPD, or There are patients who are waiting for lung transplant. You can use the echo when the patient is awake and breathing spontaneously. Another, this is a subset of patients where you should use it, and I probably think that the chances of use of echo in these subset of patients will increase by the day. Then you saw in the graph that the filter half-life usually is 3 to 5 days at maximum. We need filters with a longer half-life, especially in patients who are waiting for the lung transplant. Anticoagulation, regional citrate anticoagulation has been tried, and slowly there will be various studies and the protocols will be developed in which regional citrate anticoagulation can be used, like in the patients of CRRT. So when you talk about benefits, it allows the use of lung protective ventilation, especially to decrease the ventilator-induced lung injury. It helps to manage the hypercapnia in patients of COPD exacerbation or asthma. And low blood flow to a tune of less than 450 ml per minute allows combination with CRRT easily. The complication related to the device, the catheters, and the vascular insertion of the cannulas is definitely there, with the bleeding complications being most frequent, as in case of ECMO also. So these are the discussed uses, and I'll be talking about a few multiple choice questions now, which will help me answer. So we've discussed all these questions. I want you to participate as much as possible. So the primary physiologic target of extracorporeal CO2 removal is oxygenation, CO2 removal, cardiac output support, or hemodynamic stabilization. The correct answer is CO2 removal. As the name suggests, extracorporeal CO2 removal. So that is the primary physiological target. Which property of CO2 allows effective removal at low blood flow in ECOR? Again, this is being discussed. This is an important thing, can be asked in any anesthesia exams or critical trick exams related to CO2 transport and oxygen transport. So high solubility in the blood is the most effective thing to remove the CO2. Typical blood flow rates used in ECOR, as I told you, ECMO usually around 3 to 5 liters, but ECOR the blood flow rates are between 300 ml to 1 liter per minute. Which acid-base disorder is most amenable? Again, we know that CO2 is the thing that is being washed out, and the CO2 increase is the most acid-based disorder amenable to correction with the ECOR. The answer is respiratory acidosis. So the main ventilatory strategy facilitated by ECOR in ARDS is, so when we talk about in ARDS, especially ECOR, you know that there is the normal is the less than 6 ml per kg, that is lung protective ventilation, but ECOR is used only in patients with ultra lung protective ventilation. When we use a tidal volume of around 3 to 4 ml per kg, and the exact tidal volume is still being studied, because at less than 3 and less than 4, no mortality benefit has been shown in extravent and supernova studies. Which of the following best differentiates ECOR from ECMO? So low blood flow rates. We realize that the blood flow rates in ECMO is 3 to 5 liters per minute, whereas ECOR is low blood flow rates. Anticoagulation, membrane oxygen, and cannulation sites are similar in both of these devices. Which condition is best suited for ECOR? Again, we know hypercapnic COPD exacerbation is the best suited. When we talk about severe refractory hypoxemia, we know that we require a VV ECMO. For cardiogenic shock and passive pulmonary embolism, in which we require both the lung and the heart support, the VA ECMO is the best thing. In hypercapnic COPD exacerbation, ECOR is the best thing suited to this condition. CO2 removal in ECOR primarily depends upon, so I have discussed that. The most important thing which determines the CO2 removal in ECOR and ECMO is the sweep gas flow. So usually in ECOR you keep the sweep gas flow around 8 to 10 liters per minute, and when the initial fall in the CO2 is very high, because the CO2 in the body is high, the CO2 in the sweep gas is zero, and the gradient is very high. So when the gradient is very high, the initial CO2 drops very quickly, and then later on you have to decrease or titrate the sweep gas so that the CO2 does not fall too quickly, because the neurological complications can be there in when the CO2 drops in very significantly. Most CO2 removed by ECOR is transported in blood as, so we know the correct answer is bicarbonate. To the 70-75%, the CO2 is transported in the blood as a bicarbonate. Which physiological variable is least affected by ECOR? So another is a good question. You know that the POCO2 is affected. As POCO2 is affected, the pH and the ventilated drive is also affected. The PO2 is least affected by the ECOR because the blood flow rates are so low.